Welcome back, guys. Now in this video let's discuss about the liver pathology. Okay, now in this video I'll be mainly concentrating on this liver enzymes, how the liver enzymes are going to be changing, like what are the liver enzymes and which condition which liver enzymes are going to be elevated. After that I'll also be discussing about the alcoholic hepatitis and also some other miscellaneous liver conditions. Okay, having said that, now guys, look, what are the liver enzymes? The first liver enzyme that I am going to discuss is the transaminase. So that is AST. See, this AST, previously it is also called as SGOT. Okay, SGOT. AST means what? Aspartate amino aspartate aminotransferase. See, this aspartate aminotransferase, where it is present? It's present in mitochondria. Okay, it's mainly present in the mitochondria cell. See, in which condition the AST levels are going to be elevated? See, alcohol is a mitochondrial toxin. Okay, it's a mitochondrial toxin. So that's the reason why in alcoholic hepatitis, in alcoholic hepatitis, the patient is going to have elevated levels of AST, aspartate aminotransferase levels are going to be elevated. So this is very important, because usually in all the liver related problems the ALT levels will be more. Okay, usually in other conditions, okay, ALT levels will be greater than AST levels. Okay, that is something usual. Okay, in all the liver conditions both AST levels and ALT levels increases, but ALT is usually greater than AST. But this is the one condition, that's the alcoholic hepatitis, the AST levels are elevated than ALT levels. This is the one thing, sir. Apart from this, what else you should know is alkaline phosphatase, the other enzyme. See, what is the function of this alkaline phosphatase? See, this alkaline phosphatase is secreted by those cells which are lining the bile ducts. The cells which are lining the bile ducts are secreting this alkaline phosphatase. The alkaline phosphatase levels are elevated in which conditions? They are elevated in cholestasis. See, whenever there is cholestasis, what does I mean by cholestasis? Cholestasis means there is obstruction for the movement of the bile. Okay, there is obstruction for the movement of the bile. Whenever there is obstruction for the movement of the bile, that's called as a cholestasis. That cholestasis might be because of cholelithiasis or the gallstones. Okay, so in any condition, if there is cholestasis, the alkaline phosphatase levels are elevated. But the important point is, so this alkaline phosphatase levels, they are also elevated in other conditions. Okay, alkaline phosphatase levels are also increased, elevated in pregnancy and bone problems, bone related pathologies. Okay, now you are understanding. Same, the alkaline phosphatase is not something specific only related to cholestasis. Even in the conditions of pregnancy and bone problems, the alkaline phosphatase levels are going to be elevated. The alkaline phosphatase levels will increase. So how to distinguish that the rise in alkaline phosphatase levels are due to cholestasis, not due to some other bone problem? How to differentiate is, sir, in cholestasis, the GGT level, there is a enzyme called as gamma glutamyl transferase or transpeptidase. Gamma glutamyl transpeptidase. Okay, so gamma glutamyl transpeptidase, which is simply called as a GGT, levels are elevated. Okay, the GGT levels are elevated, gamma glutamyl transferase levels are elevated in cholestasis, not in the pregnancy, not in bone related problems. So this gamma glutamyl transferase, it is used to differentially diagnose, between cholestasis and other problems. like bone related problems. This is the one point which I want you to know. Apart from this, so the gamma glutamyl transferase levels are also elevated. See, in cholestasis, gamma glutamyl transferase levels are elevated, no doubt. Gamma glutamyl transferase levels are also elevated in binge drinkers, or whenever you do the binge drinking, heavy drinking, that can increase the gamma glutamyl transferase. Okay, binge drinker. Now, say alcoholics. See, what is the fate of this alcoholic, sir? See, the person is drinking, okay, he is an alcoholic. What might happen? Look, see, the person might get a fatty liver disease. So, what is this fatty liver disease? In the name itself, it is there. There is fat accumulation in the liver. The fat is getting accumulated in the liver. So, the patient is going to have hepatomegaly. So, question is, why the patient is having this hepatomegaly? Why the patient is having hepatomegaly and fatty liver disease? Because say alcohol, what it will do is, alcohol stimulates, alcohol favors the fat production. Okay, alcohol favors the fat production in the liver. So that fat is accumulating inside the liver, and that's what is causing the hepatomegaly. This is the one fate. Second fate is going to be the alcohol can cause damage to the hepatocytes, leading to acute hepatitis. It can lead to acute hepatitis, or even the patients who are alcoholics, they might end up in, so they might end up in cirrhosis. Okay, cirrhosis. So fatty liver disease can be seen, acute hepatitis can be seen, or even cirrhosis is possible. Now let me discuss about the acute hepatitis. Okay, acute hepatitis which is seen in a binge drinker. Now the patient is having heavy alcohol consumption. Now if the patient is having heavy alcohol consumption, he is a binge drinker. Now do you know what happens? So this alcohol is going to be converted into a substance which is called as acetaldehyde. Okay, the alcohol will be converted into acetaldehyde. Now this acetaldehyde is the real poison, sir. Now this acetaldehyde is going to damage the hepatocytes. Now in the hepatocytes, do you know what happens? The hepatocytes are damaging. There is no doubt the hepatocytes are getting damaged. Now in these hepatocytes, the intermediate filaments are damaged. So these damaged intermediate filaments in the hepatocytes, now they are called as Mallory Denk bodies. So now in the hepatocyte, if you look here in a hepatocyte, you are going to see this Mallory Denk bodies. Okay, these inclusions which are seen in the cytoplasm, these pink color inclusions which you see in the cytoplasm, these are called as the Mallory Denk bodies, which are nothing but the damaged intermediate filaments. These are damaged intermediate filaments which are called as the Mallory Denk bodies. So this is what is seen, sir. Now if a patient is having alcoholic hepatitis, okay, now he is having acute alcoholic hepatitis, sir. So the patient is going to have the general features like right upper quadrant pain. Okay, right upper quadrant pain can be seen. Now the hepatocytes are dying. So when the hepatocytes are dying, they can be jaundice. Okay, there is a possibility that he can get jaundice, right upper quadrant pain, jaundice, there can be fever. Okay, these symptoms can be seen. So these are some important points which I want you to know regarding the alcoholic hepatitis. And very important thing in labs, what you will see in the labs? In the labs, the AST levels are elevated and ALT levels. Okay, AST and ALT. Okay, alanine aminotransferase and aspartate transferase both are elevated, but AST is usually greater than ALT. Okay. Next, let's discuss about one more liver pathology, which is called as a Buttcar syndrome. So what exactly is this Buttcar syndrome? See, Buttcar syndrome, there is hepatic vein thrombosis. Now you should understand, this is the liver. Imagine this is your liver. Into the liver, who is coming? See, here I am showing you the GIT, gastrointestinal tract. Now from the gastrointestinal tract, the blood is brought via the hepatic portal veins. Now via the hepatic portal vein, the blood is coming to the liver in a simple way. I am showing you from the GIT, from all throughout the GIT, the blood is now coming to the liver. So this is hepatic portal vein. Okay. Now the substances are going to go into the liver, and in the liver, if there is any toxic substance, if there is any toxic substance, that's going to get detoxified in the liver. Now from the liver, who will come out? So from the liver, the hepatic vein is coming out. This is the hepatic vein. Okay, here is the hepatic vein, sir. Now if this hepatic vein, if it is congested, or I should say if it is blocked, there is hepatic thrombosis, hepatic vein thrombosis. If there is a hepatic vein thrombosis, what happens? Congestion will happen. Okay, now the blood cannot move forward. There is congestion. Okay, there is congestion. Now what happened to the portal pressure? The portal pressure is also increases. Okay, the pressure in the hepatic portal veins increases. So the patient is going to have which clinical features? Let's try one by one. Congestion is there. Okay, there is necrosis and hemorrhage. Okay, in the liver, sir. There is necrosis, hemorrhage because of the increased pressure in the portal system. There is necrosis of the hepatocytes, hemorrhage and abdominal pain. Okay, so there is going to be swollen liver, sir. Now because of this congestion, there is swollen liver. Now what else? The patient is going to have portal hypertension. The symptoms of portal hypertension can be seen. Okay, that can be ascites. Okay, ascites. There can be esophageal varices. Okay, ascites, splenomegaly can be seen. Okay, these are the clinical features. Like, just generally saying the portal hypertension features. Ascites, esophageal varices, the bleeding esophageal varices, splenomegaly, hepatomegaly, hemorrhoids, all these features can be seen. Question is, what is the cause? What is the cause of this hepatic vein thrombosis? Why thrombosis? Why Buttcar syndrome? So causes. The causes are number one, myeloproliferative disorders. Myeloproliferative disorders. So what are the myeloproliferative disorders? The examples are polycythemia vera. So it's a cancer, sir. Actually it's a cancer, the polycythemia vera, because of the JAK2 kinase mutations, polycythemia vera, where more number of RBCs are going to be there. So in this polycythemia vera, one simple thing that happens is the blood is going to become hypercoagulable because of more number of RBCs in polycythemia vera. It's actually a red blood cell cancer kind of thing. Okay, more number of RBCs are going to be there, blood will become viscous, so that hyper viscous blood or hypercoagulable blood can lead to the formation of these clots or the hepatic vein thrombosis possible. Now the second myeloproliferative disorder which I want you to know is CML, that is chronic myelogenous leukemia. So chronic myelogenous leukemia and essential thrombocythemia. Okay, so polycythemia vera, chronic myelogenous leukemia and essential thrombocytosis or essential thrombocythemia. So these are the examples of myeloproliferative disorder. The second condition is hepatocellular carcinoma. Hepatocellular carcinoma. So how hepatocellular carcinoma can lead to Buttcar syndrome? It's simple. So in hepatocellular carcinoma, whatever the tumor that's growing in the liver, the tumor can compresses the hepatic veins. The hepatic veins, for example, say if there is a tumor here, okay, there is a tumor growing here, that tumor might compress the hepatic vein that is going through the liver. Okay, there is a possibility. So hepatocellular carcinoma can lead to Buttcar syndrome. Okay, so that's the one thing. Next, okay guys, the third condition, which can lead to Buttcar syndrome is OCPs, oral contraceptive pills, because you know the oral contraceptive pills, the estrogens, the oral contraceptive pills are nothing but the estrogens. The estrogens can cause the hypercoagulable states, and hypercoagulable states can cause the hepatic vein thrombosis. That's the one possibility, and any other hypercoagulable state. Hypercoagulable states. For examples like nephrotic syndrome. Nephrotic syndrome, there is a loss of proteins, loss of antithrombin 3 that can cause the hypercoagulable state. So any hypercoagulable state can lead to the portal vein, so I should say the hepatic vein thrombosis. Okay. Now after this, the next topic which I want you to know is called as the Reye's syndrome. Okay. So Reye's syndrome, R-E-Y, Reye's syndrome. So what exactly is this Reye's syndrome? We don't exactly know why this Reye's syndrome is happening, but the cause is unknown. But a child who is having viral infection. Okay, now a child is having what? A viral infection. For example, viral infection like chickenpox, or is having influenza. Okay, so now this boy is having chickenpox or influenza. Now in these babies, when you give aspirin, okay, aspirin, so this aspirin in combo with this viral infection, we don't know the exact reason what is happening, okay, aspirin or any salicylate drug, the patient is going to have immediate liver damage. Okay, so the patient is going to have, or this child especially is going to have this liver damage. So whenever liver is damaged, okay, I want you to know liver is the one which maintains our blood glucose levels. Okay, it stores the glycogen. Whenever it's needed, the glycogen is going to convert it into glucose, and glucose is going to be utilized by the tissues. So liver is like a store for the glucose. It always maintains our blood glucose levels. When the liver is damaged, so blood glucose levels are not properly managed, so the patient can go into hypoglycemias. The blood glucose levels, okay, the blood glucose levels decreases and the patient can go into the hypoglycemias. That's one possibility. So whenever there is this liver damage, as usual, you know it, the ALT levels and AST levels are elevated. Okay, ALT, AST levels are going to be elevated. Now liver is the place where the clotting factors are going to be produced. Now whenever there is liver damage, the clotting factors are not produced. So whenever the clotting is not happening properly, what happened to the PT time? The PT time, okay, the clotting time is going to increase. Now liver is the place where, okay, the ammonia is going to be converted, okay, into the urea. So in liver damage, the urea cycle is not happening properly. So what happens? The ammonia levels are going to increase. So in the body, the ammonia levels are going to increase. The NH3 levels are getting increased. Now whenever this NH3 levels are increasing, this NH3, do you know what it will do? It will cross the blood-brain barrier. Okay, it crosses blood-brain barrier. Now this ammonia starts to get deposit in the, just let me cross. Okay, now this it crosses the blood-brain barrier and now it starts to get deposit in the brain. Now as it's getting deposit in the brain, it will cause encephalopathy. Okay, it causes encephalopathy. Accumulation of the ammonia in the brain is the one which is going to cause the encephalopathy, sir. Okay, and especially the point which I want you to know is the main cell which is getting damaged is the astrocytes. Astrocytes. So the astrocytes are getting damaged. The patient first is going to have the encephalopathy. That encephalopathy can lead to coma, and that coma can actually lead to death. It's a serious condition, sir. So the point which I want you to know is, sir, this Reye's syndrome, it's a rare cause of liver failure. Okay, it's a rare cause of, okay, Reye's syndrome, it's a rare cause of liver failure with encephalopathy. It's a rare cause of liver failure with encephalopathy. It is seen in which condition? Whenever the child who is having a viral infection, when he is given, okay, when he is taking these drugs like salicylates, like aspirin, there is going to be liver damage. Why exactly the liver damage occurs? There are many hypotheses, but no proper, okay, evidence is there why exactly this liver damage is happening, sir. Okay. Now, so aspirin is usually avoided in children. Okay, we have stopped using the aspirin in the children except for the treatment of Kawasaki disease. That's the important point. Note, aspirin is not used in children except for what? Kawasaki. Okay, so Kawasaki is the vasculitis. Except for Kawasaki's vasculitis, usually we won't use aspirin in the children because there is a chance that the child can have a liver failure and encephalopathy if he is having this viral infection, okay, unknowingly. Now, next condition which I want to discuss here is alpha-1 antitrypsin deficiency. So, what is this alpha-1 antitrypsin deficiency and why we are supposed to know it in the liver pathology? See, alpha-1 antitrypsin, okay, see, it's a antiprotease. Alpha-1 antitrypsin, it's a antiprotease. Okay, so actually there are proteases in your body. The proteases, what they will do? The proteases will try to destroy the proteins. So the proteases activity need to be regulated, properly regulated. Otherwise, the proteases kept on doing the breakdown of the proteins. If the proteins are getting broken down, that's a problem. Okay, that's going to be a problem. So in alpha-1 antitrypsin deficiency, the two organ systems are going to be affected. Okay, two organ systems will be affected, sir. So what are those two organ systems that are affected? Most of the student knows that lungs will be affected. Okay, so lungs are affected. Now how the lungs are going to be affected? Alpha-1 antitrypsin is not there. When alpha-1 antitrypsin is not there, when this is antiprotease, when this antiprotease is not there, so the neutrophilic elastases, okay, these are the enzymes, neutrophilic elastases. Now this neutrophilic elastases, now they are not inhibited. Okay, now they are not inhibited. So the neutrophilic elastases are not inhibited. Whenever they are not inhibited, they will cause, see in the name itself it's there, elastase, they will cause damage to which fibers? Elastin fibers. They will cause damage to elastin fibers. When the elastin fibers are damaged, the elastic recoil of the lungs will not happen. And not only that, when the elastin fibers are getting damaged, the patient is going to get a disease called as emphysema. And that's okay, that's the lung related problem. But right now we are discussing about the liver pathologies. Now which liver pathology? See, this liver pathology is going to be less common. Okay, it's a less common condition. What happens in the liver pathology is not just the antiprotease deficiency, it's not just the neutrophilic elastases are going to cause the problem. No, that's not the problem here. Here, in this condition, abnormal, okay, alpha-1 antitrypsin is produced. Okay, abnormal from the liver, abnormal alpha-1 antitrypsin is getting produced. Now this abnormal alpha-1 antitrypsin, okay, it will undergo pathologic polymerization. Okay, it's getting pathologically polymerized and it will start to accumulate within the hepatocytes. So this abnormal alpha-1 antitrypsin, whatever is there, it's going to accumulate. Okay, it's going to accumulate in liver. Okay, where in the liver? In the endoplasmic of the reticulum of the liver. So this abnormal alpha-1 antitrypsin is going to abnormally accumulate inside the endoplasmic reticulum. Now accumulation of such abnormal proteins is the one which is going to cause cirrhosis. So what is going to cause? It's going to cause cirrhosis. So now in the hepatocyte, if you say, imagine this is the hepatocyte. So in the hepatocyte, you are going to have abnormal proteins. So many abnormal proteins are seen. So what exactly are these abnormal proteins? These abnormal proteins are alpha-1 antitrypsin polymers. Okay, so how to identify these abnormal alpha-1 antitrypsin polymers? They are going to stain with PAS, periodic acid shift. Okay, so they are going to stain with PAS stain. See, what else can stain with PAS? Even glycogen, what is there? Usually there in the hepatocytes. Even the glycogen stains with pus. Okay, glycogen is going to stain positive with the pus. It will come pink in color. But the one differentiating feature between this alpha 1 antitrypsin polymers as well as the glycogen, how to differentiate between these two conditions is, so the glycogen is going to stain with the pus, but glycogen is a diastase sensitive. Okay, the glycogen stains with pus, but it's a diastase sensitive. When you put diastase, the glycogen is going to lose its color. Okay, so right, in glycogen storage disorders, again glycogen is getting stored in the hepatocytes. The glycogen is getting stored in the hepatocytes. Now they will also stain with pus, positive with pus. The glycogen stains positive with the pus, but glycogen is diastase sensitive. But our alpha 1 antitrypsin polymers, they are diastase resistant. Okay. So this is how you can differentiate between these two conditions. So with this, we have completed the video. Hope the video is helpful. See you in the next video. Thank you.